Namaste and good evening, everyone. A very warm welcome to today's webinar on evolving therapeutics in hematology, integrating novel drugs in clinical practice. We are delighted to have all of you with us this one-day webinar, where leading experts will share their valuable insights on evolving landscape of oncology and hematology. Now it's my honor to invite our program convener, Dr. Revan Bodhu, consultant hematology at Esther Hospital, Bangalore. It's over to you, sir.
Thank you very much. A very good evening to everyone on behalf of the organizing team. So I warmly welcome all of you to this webinar on the topic evaluating therapeutics in the field of hematology. How do we integrate these novel drugs in the clinical practice? So first and foremost, it is a pleasure to have colleagues from across South India joining this webinar. We are very fortunate to have distinguished faculty like Dr. Basudev joining us from Hyderabad, Dr. Satish CT joining us from HCG Bangalore, and our expert panelist, Dr. Vikram from Hyderabad, and Dr. Induja from Adayar Cancer Institute. So why did we choose this topic for today's webinar is, it is needless to say that hematology has grown leaps and bounds in the last decade, particularly when it comes to new novel therapeutic agents, which has significantly changed the patient outcomes. So there is a shift from what we used to use in the past, that is conventional chemotherapy. From there, we moved on to targeted therapies, and currently we are in the era of precision medicine. All these happened in the last decade only. However, there are certain challenges like when do we use these drugs, and how do we sequence these drugs, and what is the real world evidence for these, leave alone the data. So today's program focuses exactly on this. So the flow of events will be like this. First, we will have a beginning session, the speaker session with Dr. Basudev, who will tell us in detail about the role of zanubrutinib in B-cell lymphomas. That will be followed by a panel discussion, which will be moderated by Satish Shetty sir. And we have expert panelists, Dr. Vikram and Dr. Induja, who will give their inputs. Finally, I'll be talking about the experience with letermovir in the field of allogenic stem cell transplant to prevent the CMV infection. So without any further delay, I would like to invite Dr. Basudev to begin the scientific session. The first topic will be about the role of zanubrutinib in the treatment of B-cell lymphomas. Dr. Basudev, over to you.
Thank you, Revant and team. I'm very much thankful to the organizing committee for choosing me as a speaker in the topic. I will share my own. I have prepared the slide by myself based on the slide provided by our team. So just I'm sharing that. Is my slides visible? Screen?
Yes, sir, visible.
Yes, sir.
So today I'm going to talk about the zanubrutinib, the next generation BTK inhibition in B-cell lymphomas. I'm Dr. Basudev Pokhrel, and I'm currently practicing hematology in Hyderabad. So the today's goal will be the pharmacological understanding of the molecule, patient selection, efficacy and safety comparison, and clinical application. The slides are not moving. Yeah. So the BTK signaling pathway is the main therapeutic target for us. So BCR activation means B cell receptor activation, which is necessary for the B cell growth, proliferation, and their functioning. So here the therapeutic target for our BTK inhibitors are the cystatin residue at cystatin residue 481, the irreversible signaling blockade. The slides are not moving fast. So the first generation BTKI was FDA approved in 2013 in the name of ibrutinib, which has revolutionized the CLL and MCL therapy. So, but the main problem was the side effects because of lot of off-target kinase inhibitions like EGFR, TEC, and SRC kinases, and there are many more. So there was treatment discontinuation rates in both the CLL as well as MCL. Nearly 30 to 40% patients discontinued the treatment of ibrutinib just because of the side effect and non-tolerating the drugs. The selectivity is important for the reason because the ibrutinib inhibits all other kinases and receptor non-selectively. So there was EGFR inhibition resulting into rash and diarrhea, TEC inhibition increasing bleeding risk, just like a platelet function disorder, and SRC inhibition related to atrial fibrillation and other cardiovascular side effects. So the solution is in the form of zanubrutinib, which has a higher BTK selectivity, reduced off-target inhibition, and sustained BTK occupancy and better tolerability profile. So zanubrutinib, the molecule is so precisely invented through the engineering methods that it had a sustained BTK occupancy and continuous inhibition without other significant drug interactions. So rapid absorption with a Tmax of 2 hours, steady state concentration, no food effect, and minimal drug interactions. So zanubrutinib has a highly selective effect compared to other molecules, which has preserved the efficacy with reduced toxicity. So the pharmacokinetic advantage of zanubrutinib giving BID has a sustained steady concentration compared to ibrutinib OD, which has the concentration would drop and the efficacy would have to change accordingly. This zanubrutinib has been approved by FDA for the 5 major indications: CLL and SLL, and Waldenström macroglobulinemia, mantle cell lymphoma, marginal zone lymphoma, and follicular lymphoma. So it is the only BTK inhibitor approved across all 5 major B-cell malignancies. The standard dose is 160 mg twice daily, no interactions with the food. And if OD doses also can be given, however, there won't be as much as steady state concentration. And while talking about the zanubrutinib, we should discuss the key pivotal study trial like the Alpine trial, which is a phase 3 randomized trial, where this is a head-to-head comparison of Janu versus ibrutinib in relapsed refractory setting. So total 652 patients were randomized in zanubrutinib arm and ibrutinib arm, the 160 mg twice daily Janu versus 420 mg OD ibrutinib. They have stratified the factors like deletion 17p status, prior BTKI exposure, and geographic regions. The primary endpoint is ORR, and the secondary key secondary these are the patient characteristics, and the response rate ORR zanubrutinib 86.2% versus ibrutinib 75.7%. So the CR rate was higher with Janu, and the lower progression means higher progression-free survival. The time to response was similar, and the progression-free survival curves were also, there was a wide separation of the curves, and the high-risk populations included in the study were deletion 17p, IGSV unmutated, and bulky disease. in all this, the zanubrutinib overcomes the poor prognostic features. And the most important, the cardiac events. The cardiac event with zanubrutinib was 5.2% as compared to the ibrutinib, which was 13.3%. So actually there were no death related to cardiac events in the zanubrutinib arm, whereas there was 6% death in the ibrutinib arm. So the alpine safety, the zanubrutinib demonstrated longer therapy duration without interruption because the patient had fewer side effects, better quality of life, and more patient remains on effective therapy. And the quality of life also significantly improved in the zanubrutinib arm. From the alpine study, the take-home messages were the superior efficacy, better cardiac safety, and also effective for high-risk profile like it maintains in the deletion 17p TP53 mutated disease. It has shown its efficacy. So zanubrutinib had established a new standard of care for relapsed refractory CLL, offering superior efficacy and significant improved cardiac safety. The another trial is the Sequoia trial. This is the first line. This trial was conducted in the first line setting newly diagnosed CLL. It is a phase 3 randomized trial which compares zanubrutinib versus the chemotherapy bendamustine rituximab. So they have divided into many cohorts. Like cohort 1, they included Janu versus VR. It is a randomized. And cohort 2, the single arm zanubrutinib in a deletion 17p positive patients. And the arm D, they have discussed about the fixed duration combination of zanubrutinib and venetoclax. So the first cohort comparing zanubrutinib with the chemotherapy bendamustine and rituximab. The same dose 160 mg twice daily was given, continuous therapy until progression, and 6 cycles of bendamustine rituximab, which is the conventional chemotherapy for the CLL. They have compared. So the primary endpoints or progression-free survival by IRC, Independent Review Committee, and the secondary or overall survival, ORR, safety profile, and MRD negative status. So the results, though the median PFS was not reached, but there is 50% risk reduction in the zanubrutinib arm. So the overall survival was 94.6% in the zanubrutinib arm, and complete response was 14.6. So it proved the superior chemo-free option for first-line CLL. The second cohort is for the deletion 17p patients. The deletion 17p patients in any form of malignancy are the poor prognostic factors. But the zanubrutinib established as a first-line option for high-risk CLL. We know deletion 17p, the chemotherapy is theoretically and almost it's contraindicated, where zanubrutinib becomes the first-line option for such patient having the deletion 17p mutations. The Sequoia ARMD has the chemo-free combo, zanubrutinib plus venetoclax. This arm discusses about the fixed duration therapy, but it should be MRD guided. And there is no progression in TP53 mutation patients at 24 months of the treatment. So the blood MRD negative after 2 years of therapy was 67%. So we discussed about the fixed duration versus continuous therapy. The continuous therapy is still the standard of care as of now, whereas the fixed duration is still the investigation combination guided by MRD negative which may not be feasible in many parts of the country. So still we are practicing the continuous therapy. The goal is to maintain for pre-survival. The Sequoia safety profile also says that the janitary arms is more safe in terms of cardiac events, infections or comparable, and neutropenia will be more with the chemotherapy arm. So research transformation is rare and comparable to chemotherapy with no increased risk with zanubrutinib. So comparative effectiveness through multiple analysis, matching adjusted indirect comparison, and network meta-analysis all showed that the zanubrutinib is superior to chemotherapy as well as the ibrutinib and acalabrutinib. And the zanubrutinib versus venetoclax and obinutuzumab, they showed that zanubrutinib demonstrate comparable, if not superior efficacy to time-limited chemo-free regimens. So choosing first-line CLL therapy, first we see the patient fitness as well as IGSV mutated status. If the patient is young, fit, still we can consider the FCR chemotherapy versus zanubrutinib. We'll discuss patient risk, patient preferences, and benefits of chemo versus chemo-free regimen. If the patient is unfit or TP53 abnormal, then zanubrutinib monotherapy or combinations, but no chemotherapy. Fixed duration candidates will consider zanubrutinib plus venetoclax. If MRD-guided therapy is desired, it is still investigational. Any cardiovascular comorbidity will choose zanubrutinib over ibrutinib without any doubt. Then next indications of zanubrutinib is Waldenstrom's macroglobulinemia. The ASPEN trial is the landmark trial here, which is the phase 3 study with MYD88 mutated populations, and it compares zanubrutinib versus ibrutinib. MYD88 is prevalent in 90 to 95% of the patient populations. This is BTK-dependent survival signaling. And in those patients, the CXCR4 mutations is prevalent in 30 to 40%. So before initiating BTK therapies, we have to test for these mutations. So in the ASPEN trial, they have divided two cohort design population, one MYD88 mutated and CXCR4 wild type. And the design was Janu versus Ebru, and it's a randomized. And the second cohort, MYD88 mutated and CXCR4 mutated, means both mutated, where the design was Janu single arm. And the primary endpoint is the very good partial response rate. So CXCR4 mutations affects BTKI response kinetics. It is important for the patient's counseling as well as expectations. And these mutations are means poor prognostic markers. So the in ASPEN cohort results, the VGPR is numerically higher with zanubrutinib, and the IgM reduction is faster and deeper, though the efficacy is similar, but the safety is more with the zanubrutinib. And in ASPEN cohort 2, where the CXCR4 mutated patients are taken into consideration, it showed that the therapy zanubrutinib remains active despite CXCR4 mutation. It is an important salvage options. And the ASPEN safety, the hemorrhage and atrial fibrillations. So The superior safety profile is documented with zanubrutinib. So zanubrutinib measure hemorrhage, atrial fibrillation, and hypertension all or less in the zanubrutinib arm. So in the Waldenstrom macroglobulinemia, there is IgM flare possible with BTKIS. There is a transient IgM may increase after initiation. So we need to counsel the patient. CXCR4 testing is recommended before BTKI. So the approved indication is first line as well as relapse refractory Waldenstrom macroglobulinemia. It is globally approved based on the ASPEN data. So the pool safety analysis from all the studies shows that this zanubrutinib shows all the five major side effects in the lesser extent compared to the ibrutinib, like atrial fibrillation, hypertension, major bleeding, diarrhea, and rash. And the most common mechanism being the selected kinase inhibition, unlike ibrutinib, which inhibits multiple kinases and receptors non-specifically. So the cardiac, also already I have told, there is an 83% reduction in the cardiac death in zanubrutinib arm. And bleeding risk, because the BTKI causes the functional platelet disorder in the form of platelet aggregation. So there is bleeding risk. So any patient undergoing surgery or any planned elective surgery, we need to withhold the BTKI. Being the half-life of zanubrutinib less, we can withhold. Zanubrutinib is comparatively more safer in such situations. The infection risks and COVID-19 are almost similar in both Janu and ibrutinib arm. So the BTKI tolerance and switching, if one patient is intolerant to ibrutinib and acalabrutinib, in such cases also we can use zanubrutinib. It still works and patient will tolerate. Mostly it is because of the more favorable safety profile. So the another indication is follicular lymphoma, relapse refractory follicular lymphoma. In more than 2 lines of therapy already the patient had. The combination is zanubrutinib and obinutuzumab, as in the Rosewood study, where the BTKI inhibition may enhance anti-CD20 activity through modulation of tumor microenvironment, and the BTK inhibitor and the anti-CD20 inhibitor may have the synergistic effect. So the first BTKI combination showing benefit in follicular lymphoma. And some drugs are still investigational. And mantle cell lymphoma also, the study VGV 311206, where the mantle cell lymphoma prior to one relapse refractory, prior to one previous chemotherapy has been also tried, and the results are promising. And it has also addressed the high-risk MCL like TP53 mutation, blastoid variant. Prior chemotherapy, the ORR is 92%, better outcomes with earlier use. And we need to consider sequencing here. So consider early use of zanubrutinib in MCL. So the key take-home messages from the various studies regarding zanubrutinib is it's a only BTKI approved across CLL, SLL, WM, MCL, MZL, and follicular. Superior cardiac safety, high risk efficacy in effective in deletion 70p or TP53 mutations. We can switch if patient is intolerant to ibrutinib or acalabrutinib. And future is the fixed duration combination, which is still investigational. So zanubrutinib represents the current standard of BTKI inhibition in B-cell malignancies. Thank you.
Thank you very much, Dr. Basudev. That was very comprehensive and detailed discussion about CLL in particular and other low-grade B-cell lymphomas as well. If there are any questions, you can post it in the chat box or ask Dr. Basudev. I have a question. So there's no doubt about the safety and efficacy compared to what we used to see with ibrutinib and acalabrutinib. But coming to the upfront settings, leave alone the high-risk patients where you have selecting zanubrutinib. Coming to fit and standard-risk patients, is your first-line bendamustine rituximab or obinutuzumab venetoclax?
Still, because of the cost factor and other issues and availability, I am still giving bendamustine rituximab as the first line, unless the patient are TP53 mutation positive.
Okay. Any of the faculty had experience with obinutuzumab, because we have used for quite a few patients and all of them crashed counts like anything, and we are not able to continue the drug further even before we started venetoclax with obinutuzumab itself in the first cycle. So anybody can, Satish sir, if you have.
Yeah, we have used the obinutuzumab that see, like when you're using bendamustine, like beginning, like definitely we have to be weekly monitoring the blood count. Other things are very important. Yeah, that tumor lysis like that we try to definitely will see that monitoring counts are, like is very very important. There is a patient we lost also one of the patient, but majority other patient what we have treated, like we learned actually that monitoring that blood count and taking care of the reporting, like patient reporting anything support like this kind of any fatigue, like extreme, like any variations of symptoms, or we'll tell them to rush to the hospital emergency. With that, like definitely that we're able to solve it. But one patient had a very bad experience actually. Otherwise, like we're able to manage well. Yeah.
Thank you, sir. Thanks for your inputs. Thank you, Dr. Basudev. That was an excellent session. Let us move on to the next session, which is optimizing the care of CML or outcomes in CML with the availability of asciminib. For this session, I would like to thank and invite Dr. Satish CT sir. I would like to first thank him for accepting to join as moderator in this webinar. Satish CT sir is a senior consultant medical oncologist and hematologist at HCG Cancer Center, Bangalore. And I would like to ask sir to take over the session and introduce his panelists. Thank you, sir.
Can I share my slide?
Yes.
Yeah, just 1 minute. Yeah, my slides are visible now.
Yes, sir.
Yeah, I think we have both our expert panelists. Both are there. Like just I have to call them actually.
Yes, sir. Dr. Induja and Dr. Vikram, both of them are there.
Both of them are there, no? Dr. Induja and Vikram. Yeah. Yeah, see that like I'm going to talk a journey of the that how the management of CML has evolved, because before, like when the CML treatment we didn't add any target therapy, that we they used to have only conventional treatment, hydroxyurea and like interferon, other thing, those kind of things were there. Definitely with the identification of BCR-ABL, the target therapy is available. Like then things have changed actually. The first the TKS, that imatinib target therapy was developed. After that one, like various molecule, first generation, second generation, and whereas newer molecule has come actually. See here, like I'm going to discuss like what are the importance of, because we have in oncology lot of newer molecules are coming. The second generation to third generation, they're taking care of the thing. The best drug you have to use it to the first line, rather than like the sequencing, because many times we used to do sequencing of treatment, first line, second line, third line, all the thing. Let us see that how the practical the thing management we do day to day, and we learn from one another experience actually. Some people like we do well, like the what is to have older way of first line, second line, third line, like those things. Let us see that like can we use the best drug in the first line, what is the experience, and how we can able to manage. See, as for the stamp, that is the specially designed this drug for with asinib first line to the relapse of CML patient, how will you manage with this asinib molecule. That is the newer the target therapy that available with CML patient. This my disclaimer. Coming to the newly diagnosed CML patient, this is the hypothetical case. Like what I wanted to say that actually this is a 35-year-old female newly diagnosed CML. Many times we try to our Indian patients mildly intermediate to high risk. Actually, intermediate risk majority time we'll see that, and low risk also we might come across that. This patient had a female with a low so-called score, was a young and career oriented professional patient, highly motivated to adhere to the treatment. That main thing is sometimes potentially that people are very enthusiastic. I'll take treatment when their things are better. The compliance and adherence to the treatment is very challenging. Actually, that's why we try to have a lot of treatment failures will happen. Actually, that like a concern about the that potential side effect also, like because the what are the drugs are all well like long term the side effect and the quality of life is also is matters. The patient wants to have provide highest chance to have a deep and durable response to for a potential future treatment free remissions, because this has been when CML treatment was started with imatinib, it is a lifelong treatment. Later the data has come, okay, we can start that, we can stop the drug, but when the patient is achieved the goal achieves the milestone at the right time, and patient is persistently maintaining the remissions, we can even stop that one. The stopping that evidence has come with imatinib and even other second generation drug, and even this the newer drugs also. The discussion is like this is the doctor like Vikram. See that like this patient is very active and like without any comorbidity, like when you are maintaining the quality of life, which are the drugs you try to see that like newly diagnosed like this patient, you try to see efficacy of the drug, safety, and what is your first line of treatment options in a this, newly diagnosed CML patient? Dr. Vikram,
Sir, very good evening.
good evening.
So a patient like this age group, 30, 35 years, who is very young. So in this patient population, our aim is not only to get the disease under control, but also can we get her off medication in some time. So these are the two targets what we generally keep for these kind of patients. So so in doing that, to achieve that, so what are the best medications we have? So generally for this group of population, we generally start with second line TKs. My first will be the dasatinib or nilotinib, so that we can achieve early major molecular response, and so that we can achieve DMR and go for TFR. This thing. The other things what we consider before we start treatment is like what are the patient preferences, whether she's comfortable taking medicines once a day or twice a day, because that certainly be even once a day is sufficient. Nilo, you have to take it twice a day and with dietary restrictions. So, what is the patient preference, and what are the side effect profile? So, those things we take into consideration before we start any treatment for this. Another important, especially being for a woman, we all are for a men also who are like unmarried. We try to get the disease under control so fast so that she can go for a family also. So all these things we take into consideration before we start treatment for this age group.
Yes, yeah, definitely. Dr. Vikram rightly pointed out all the things. Yeah, the imatinib we used to use it actually. Low score also used to use it. Intermediate and high risk we used to use the second generation like a nilotinib, dasatinib. That was most of us our practice. Now with availability of newer drugs are there, like this asinib is one of the drug is coming actually. That's what we have to see that whether how we are taking in first line treatment, other thing how like because yeah generally the various factor regarding the so much of factor like the each drug having a different kind of spectrum of toxicity also, and also like the comfort of the taking the pills daily and the compliance adherence is very very key important. With the many pills means the patient definitely doesn't like it, we'll try to see in a different way. Let us see that like because we have a drug known as asinib is the one of newer drug is there, that is how it is Dr. Induja, how you see that because we have so many drugs are bosutinib, so many drugs are there, like how you feel like this ATP competitive TKs are there, how do you feel like choose this drug actually, because we have data from the ASI for the first study that I'm going to say it in a like because that is try to see the best like achieving the goal in the form of like deep molecular response and quality of life and early molecular response also. How do you see that about this drug over the other drug?
For such a young female, like who is very active, who doesn't want much side effects, and for whom the deep molecular response and TFR is needed, I would definitely go for a better drug in the first line. So till now we had data for dasatinib or using a second generation TKA. Now with such a strong data, if logistics is not an issue, I would definitely go with asciminib in the first line.
Okay, that the data is there in the first line. You are convinced like this drug is like appears to be promising actually that second line, third line, that's like when a failure to our lines actually sometimes resistant cases are the things we have a data. The first line data is you if it's there convincing, you have a good data, then the other drug you are convinced to use this drug.
Yes, sir.
Okay, okay. Yeah, this like this patient like the primary aim is to we have to give the the goal is to achieve the best disease control and try to have a rapid and deeper response and early molecular response. That's what if you achieve the early molecular response, major molecular MMR, DMR, definitely we try to what both of us our experts says that like you can achieve go for the early treatment free remissions that potentially for that. Definitely that every drug is having its own kind of toxicity that we supposed to have the very least toxic drug and allows to that like because that helps them to have the compliance of maintenance of the on the patient on duration when the patient is on treatment they try to adhere to the treatment that gives the important to have achieve this one best response and we try to go for a treatment free remissions also. If we don't have compliance is the issue because of toxicity they definitely the long term outcome will be don't get it actually you may be a early response you may get it some other drugs but like long term achievement it won't happen for a TFR like that's why like the data is there with the various molecule you can see the MMR by DMR by 2 years MMR by 1 year you can see that like a long term achievement and going for a ultimately TFR like you can see that the we have a data for imatinib and nilotinib that and you have a decision study that is dasatinib imatinib and we have before study with the positinib we can see here compared to imatinib I'll agree that everyone is like I think staff using imatinib where many of us were using the second generation either nilotinib or dasatinib anyone is using Dr. Vikram are you using bosutinib anything we have a data is there but we are more convinced for the that
No.
yeah.
So only one patient I have used bosutinib, sir. The patient already failed imatinib, nilotinib, and dasatinib. For that patient, we have used bosutinib. That time, Simni was not in the market that time. So that's the only patient I have used. Otherwise, not so frequently.
Okay, yes. And Dr. Induja, do you have any experience with that?
Bosutinib not in the first line or like only if they are not like
Yes, yes, yes.
not
We are
have.
we are desperate actually. We don't have other like
Mm,
panatinib and this dasinib was not available. Desperate we are like we all the three drugs are a failure that we try to use it actually but definitely that the second generation drugs are better than imatinib this data says that definitely we're convinced that second generation drugs we can use it and you can see that like when you're going for MMR4 like MMR 4.5 that and the 4 and the 4 years the patients that achieving the that B cerebral and remission and control you can see that that is if the patient achieve the earlier like EMR that is early molecular response they try to have the long term control that's what is the one thing important actually and lower rate of disease progression deeper molecular responses we're going to achieve that that's the one thing important that's what is the data says with all over to various studies and you're shortening the half life like if you're associated with like that if you're the duration of this the going for a half life of decreasing that the appreciable level is decreasing very early in a quick short time definitely you're going to have a EMR and even deeper responses very quickly and you will try to go for the TFR early. See that like definitely when you're considering any drug, we definitely like we'll try to see that treatment related toxicity and intolerance to the drug. That is, it can be one drug, it may be two drug, You can see that definitely lead to reduce the quality of life. Treatment discontinuation will be there. Suboptimal dose also because of the treatment interruptions and dose reductions. That and suboptimal user patient complaints also will definitely goes down because they learn actually if you stop the drug, I'm feeling better because of this to escape of the toxic adverse event, then definitely that you're not going to achieve the deeper molecular response what is supposed to achieve. And non-adherence and switching of therapies, these are the various factors are there, like the intolerance to the therapies, that is very important. Definitely is going to impact on the quality of life. And also ultimate game of that what we are achieving the MMR DMR. This is the, and ultimately that our aim is to stop the drug. That is like the TFR is going to eligibility comes down. That's what like we have to achieve the best treatment in the first in the beginning only. Any drug actually, that's what we try to see that this is the if this is the data. If you see that intolerance resulting in the like intentional and non-adherence, it may decrease the patient probability of achieving the optimal response to treatment. You can see here the MMR, like you can see here, like what you see that adherence. This is the red one. You can see the adherence is less than 90%. You can see that what your MMR is going to achieve less. If more than adherence is more than that, a blue one is like more than 90%. Definitely, you're going to achieve the MMR is better. MMR4 also, MMR CMR also. You can see that you can achieve better when that is the study from the imatinib. And we have like data from other drugs also. This is the thing like the probability of like achieving the MMR in based on the adherence. If adherence is not good, definitely you are achieving the less the outcome as per this data. Like similarly, that's what like the toxicity of any drug is important. We have this, they are the multiple drug, the first generation to second generation, ponatinib and bosutinib. You can see that they are all ATP competitive TKs. They are off target than that these can cause the drug intolerance affecting the quality of life. That's why that this newer drug asinib is different actually. Switching over, like we may try with the imatinib, nilotinib based on the mutation studies we have done. Everyone has experience with this kind of thing, but every drug is having its own side effect, and they'll eventually become resistant to the drugs. They're mainly competing with the ATP competing sites. This asinib is of the specially designed, that is known as it works by stamp, that is specially targeting the ABL like a myristoyl pocket that you can see here actually. This is the ATP binding site, and we have the side chain, and you can see the kinase domain, and you can see myristoyl. The pocket is there here. This is the one thing that's normally it's like inactive ABLs will be there in CML. Like most of the ATP binding site, all the thing drugs will come ATP. The binding, the TKS will come here. But if these things are bonding is not good and the resistant mechanisms comes here, it can be kinase dependent or non-kinase dependent. You can have ATP binding sites. Then we can see the various type of mutations they come. That's why it may eventually they become early. This drug is specially targeting this. The like stamp what I said is actually that is like it is definitely gives the better disease control compared to the, and also side effect profile also different compared to the other ATP binding that what we have the TKs. You can see here MMR at 48 week is superior with this asinib. You can see here like 67% versus 49%. Compared to the other molecules, you can you try to see this. And similarly, you can see that like all asinibs and can compare to that. It's try to have a better like a disease condition having highest statistical significance and higher proportions of patients with the asinib, like they're going to achieve the early molecular response. You can see here compared to the that other TKs compared to the asinib. You can see here left side, and BCRable the response also you can say less than 1%, and MMR4, MR4, MR and MR like a major response 4.5 also you can see you can achieve best with the that asinib compared to the other TKs. You can see here deeper molecular response. DMR at 96 weeks also is to be highest. You can see compare the asinib is compared to other all the other data you can see here. That you can see that MR4 also MR4.5 also you can see that this you try to achieve the best with the asinine compared to the other molecules. Similarly, you can see the all the things like you can it is try to have the deeper response or better with the asinine if you use in the first line. Coming to the toxicity, that's one of the thing we have convinced with the that efficacy is better compared to the other molecules. We have that the toxicity. You can see that acinibis have tried to have a lesser incidence of the side effects when compared to the that we have a 96 weeks of the data of toxicity. We have this. You can see here thrombocytoma slightly numerically slightly more like the grading, but grade one, grade two, like the grade three toxicities are like less. All the toxicity you can see here, headache, anemia, other muscle spasm, like various toxicities are there all less actually compared to the other molecule, the acinibisam less. And you can come into the that discontinuation also. Many patients they try to have a dose interruptions and discontinuations. You can see that you have a imatinib is more like as in when have more chance of discontinuation. You can see here imatinib 46% when compared to the asinib is like less actually. And that like you can see that other like chance of disease progression and various other factors, all the things are we try to have a less chance of discontinuation when the patient is on asinib compared to the other molecule. We have a data that's as per the AC4, the first study, that is the first line that asinib in the imatin CML. You can see that like compared to other second generation TKC, you can see here the discontinuation rate also you can see less, and patients are going on with the asinib versus the other second generation TKS are numerically is higher with the asinib. The patient is on treatment, and treatment failure also, even progression and adverse events also you can see that there are less. That it means that like it is the quality of life is better when patient is on asinib compared to the even second generation drug. Summary of this the first line, that is uh, the first line data with the ESC4, that 96 week analysis. What you see this asinib continues to demonstrate a superior efficacy compared to all the other international accepted, that is TKS, and MMR also you can see highest with the asinib compared to the imatinib. And treatment difference, that is the MMR like rate is increased from 8.2 to 15% at week 96% compared to the other molecule. And DMR at 96 also is highest with the asinib compared to the other TKs. With this data, asinib is safer and tolerable. The profile come better compared to the imatinib and other second generation after the long term follow up of 96 weeks. It was consistent to have a safer profile, that better safety compared to the other first generation, second generation TKs. The twice proportional patient discontinued with the other TKs compared to the asinib with respect to the adverse event. With this, asinib is the favorable benefit profile compared to the other all tyrosine kinase inhibitor, including imatinib second generation TKs in a patient with a newly diagnosed chronic myeloid leukemia in a chronic phase. It reinforces the use of this molecule as a standard of practice in the patient with the newly diagnosed CML. This is the newly diagnosed CML patient. Coming to the that, because many times, because this is the one thing data when our patient options comes means, because when a CA lung patient is there, like we used to use osimertinib, we used to use in a late reserve actually. We used to use geftinib, erlotinib and other drugs. We try and later osimertinib we used to use it. People are coming to reaching to osimertinib, the patient will be deteriorated and definitely may not go to that. If we use the OSMT first line, definitely we are trying to we have a better, like how we are using best drug in all the disease, like in the newly diagnosed, try to have a best and long term good result. That's what is that this data is more like impressive and they can easily convince to use this drug. Coming to the that pre-treated CML, because already these patients are exposed to the previous drug. This we have this other one more case. 45-year-old working professional, you can see here 6 month like history of fatigue, general malaise and weight loss, was at mild tachycardia, palpitation with enlarged spleen. And you can see the workup has done with the blood count, other thing almost 3 lakh count is there, and basophilia also is there, and mild hepatomegaly and massive splenomegaly is there. Patient with the bone marrow aspiration and hematological, all the tests is saying that is a chronic myeloid leukemia in a chronic phase. The investigation additionally flow cytometry, that all the things like and the cytogenic analysis also done is showing the field of chromosome, and that fish also like that is done actually. B cerebral also is positive, and that B cerebral this quantitative analysis also almost 84.5%. Coming to the treatment, this patient was treated with the imatinib initiated actually. Then patient by 2 months you can see complete hematological response was there. At 9 months you can see lack of complete cytogenic response and major molecular response at the 9 months. Then because of this one, because these milestones are there, we have a guidelines are there. But if we don't achieve that, they generally we may do. Some people they do the resistant mutation test. People generally switch over to some without doing test. Also, some people they try to do switch over to either dasatinib or nilotinib. That's based on the individual clinician practice. This patient was changed to dasatinib 100 mg per day because the patient later is developed a lot of side effects. You can see the severe headache, diarrhea, fatigue, other thing, and they didn't achieve what's supposed to achieve the complete cytogenic response, and the MMR is not achieved with this. To Dr. Vikram, that what is the reasons for treatment failure? Like this, just wanted to hear from you this case.
Sir, in case of CML, the reasons for failure are two. One is a patient adherence, whether the patient is taking that TKIs properly or not. The why the adherence is poor, again, two reasons: whether the patient is negligent as such, or is it because the patient has intolerance, or patient has side effects, that's why he is not taking. So that is the one reason. And second is the resistant clone. The clone of CML might be resistant to the particular TK, so that might be the reason it is not responding. So this we need to evaluate by checking the history whether the patient is adherent to or not. If he is adherent to the treatment, then we have to check for the mutation analysis.
Okay, okay. Dr. Induja, do you have anything points to say add up actually?
There are like two things. One is adherence. Second one is if there is any imatinib, IRMA, any mutation which is making the drug resistant. These two we have to see. Third thing is like usually when patients get well, they have the tendency of stopping the drug on their own. Basically, it's non-adherence. That's the thing. Nothing else which we see.
Yeah, yeah, I think both of you rightly said is like, see, the first thing is the treatment failure, like this is a high risk case will come, massive splenomegaly, high count, all the thing. That's what I say. If you go, the so-called score is coming high. Are you right in starting imatinib? Because imatinib, I think no one starts actually. I know this is the hypothetical case is started early, but if we newly diagnosed, we feel that we are not, at least many of us, anyone is try to start with the second generation rather than the imatinib that we don't. That is one of the reason. And the patient on first generation, second generation, like relatively, they are first generation, second generation. On treatment progression, resistant mutations, clones develop early, and we may not achieve the response EM, early molecular response. That what is shown here actually 9 months supposed to achieve that, it didn't achieve with imatinib, and even later when start to like switching out to other drugs, that definitely that adherence, all the things, like because initially they may feel comfortable. Patient also they try to learn actually with initial some therapies, like there was some drug like imatinib, and that you start for a toxicity, and even these other drugs also. Adherence is the next very important actually. That data is already supporting for this. The adherence is the why question comes with, because of the toxicity that is second generation. If you start newly diagnosed case also, or even if you use a second line also, that is the one thing. Adherence is the one major thing. Second is like without doing IRMA, like I think Hindu side, like you said, is really IRMA is the one thing that we try to do it. That, see, without doing the mutations, that people, that some people they try to start. Okay, anyway, this I'll start with other drug. That if that doesn't work, I'll try to change. That is the people like, yeah, that now like with a lesser cost we can able to get it. Previously, people used to worried about that, because if you don't select the right drug, if you don't identify, definitely that is the one of the treatment failure is there. And adverse event, definitely that Vikram and one and in the both we have pointed out, the adverse event definitely is going to cause impact on the adherence, and definitely is going to have that outcomes. That's why we try to use it. Does it like that? Because how do you do it? Like because people like Hinduja like that. Because I use imatinib. Some people they see that I try to use the dasatinib. Some people they try to use the imatinib, the nilotinib. Sir, what is your this one actually? And Hinduja actually.
Sir, as of now, what I'm practicing is like for younger people for whom we are aiming treatment-free remission, I go with second generation TKI.
Mm-hmm.
Rest of them, I give the choice, like whether it's imatinib or dasatinib or any other second generation TKI for elder ones specifically, because the complications with dasatinib, I feel, is slightly higher, which we see practically, like they end up with too many cytopenias. We have to reduce the dose as low as 50 mg, 40 mg. So unless it is for a TFR, I start with imatinib in at least in elder patients. This is what I follow. And like if they are like having logistics is not an issue, I give the option of asciminib also now, like at least for patients with comorbidities. Like I have one patient with diabetes, hypertension, and AF. She has this AF. For that patient, I straightforwardly gave the option of asciminib in first line. So these are the things which I would consider.
Okay, Dr. Vikram, anything you want to add up?
Uh,
Vikram, are you there? See that second generation, like many of us, like we try to see that, like Dr. Induja has told, like the dasatinib, yeah, we have a lot of toxicities there. People they may use it low dose also, 50 mg also. They try to use it 70 mg, like that. The people are even comfortable also, but the managing every patient, even second generation, even though like even better than imatin. That's what I can say. We are like data is there, like even either even the dasatinib or nilotinib, like we try to use it, but still we face the the adherence issue with those kind of drug, even you are trying to go with the lower dose also. And definitely that even resistant clones developing and an adherence issue and treatment failure, we try to see that. Definitely second generation with availability, that survival chances is improved actually, what we used to see earlier with imatinib. Lot of many patients are there with imatinib, but blood counts are normal. If you do the molecular test, they are not in a remission at all. But somehow they used to control that, the right to use. That's what, even though if you see that the overall survival rate is not much marginally improved, but the patients are growing, progressing to the blast crisis, aggressive phases. They used to see more with imatinib compared to second generation. Definitely that has improved actually. With this newer drug, definitely ascending like the quality of life, what we say that, and also early response, what we have a data actually, that asinib for first study, that definitely is giving the good like the outcome. And Dr. Vikram, the can side effect like what you seen that, like I think is maybe the repetition question. Side effect profile, does it like impact your treatment of your CML patient day to day with a different molecule?
Yes, yes, sir. The side effects definitely, because some patients with DASA will developing pleural effusion, some patients with nilotinib developing pancreatitis and all. So all these things will definitely affect the either we reduce the dose, sometimes we discontinue, or so all these things will affect the efficacy of the particular drug. So that may not result in the result what we expected the outcome. So definitely the side effects will impact the outcomes.
Yes, definitely. Even though second generation appears to be better than first generation, but side effect, what rightly find of like fusion is there, like mild, okay, somehow is we might manage. Persistent pleural effusion, pericardial effusion, we have to stop it. We may do course of steroid, diuretics, all the things we try to do a lot of things and dose modification. But definitely those kind definitely impact on the outcome. What rightly pointed out with the dasatinib, even nilotinib also, various kind of not only pancreatitis, even that GA tolerance of the drug, and like those things, multiple things we can get it. And skin toxicity with nilotinib also, that we try to have different kind of thing, body pain, all the thing. But Dr. Induja, like how do you say, like I think that you are, I think what you said is previously, like cost is the one factor. You are saying that otherwise you are convinced, if you are any case comes with cost not a matter. What is your first preference now? what is evidence of this one? Like the Sassanib is the that your choice of treatment in a first line. Okay, the second line failure, definitely we have to go that we don't have much option. This is the drug of choice. The first line.
Sir, if a patient is not tolerating second generation TKA, now I am now completely convinced that juggling with another second generation TKA is not going to do any help to them. So, to prior treatment lines failure, either we should offer them asciminib or like there is data for stem cell transplant also. These should be the option. So if the patient is not very much keen on stem cell transplant, I think we should go for the asciminib. And I have
Sassanib is
Mhm.
yes. Well, your expense you can say. Yeah.
Yes, sir. I have one or two patients who like post 3 lines of treatment now started on asciminib. They have a good molecular response also, and toxicity profile is also good, and like tolerance is good. So I think like both in first line and if not exposed in first line, this drug should be the choice. Because like
Yes.
when we are using other TKAs in the first line, there are high chances that there will be resistant mutations emerging, as we have seen with other cancers also.
Yes.
So
Yes. Yes.
if cost is not an issue, I think we should go for it. Post asciminib failure, like we don't have much data, we have to see. But as of now, I am convinced to use this.
Okay, in the second line, you are convinced like sort of failure to the second generation. You're not like juggling with other changing to other second generation. You're convinced
Dr.
easily.
Satish,
Yeah,
sorry to
yeah,
interrupt you, sir. Please
yeah.
conclude in 2 minutes.
Yes, yes, yeah. Okay, this is like definitely that I think both our the experts are convinced actually there's a rate where for treatment failure with what we see the imatinib second generation what we see that definitely that outcomes like not good actually that they might use changing to one second line to other second generation TKS all the thing but still that achieving the long term goal is not achieved with this kind of thing because this ATP competitive TKS, the main outcomes are not very optimal. They try to have a overall survival rate, like because the kind of mutations they're developing not may not work also, and also toxicity and adherence is a major thing that we try to long-term response may not achieve with the that second generation by changing that. You should be prepared mentally achieving this. That's why we have this drug that is rather than juggling with the typical competing TKs, we have that the special mutation. We know that this is the area we cannot go with any other drugs. We have to go with the Cineb is specially designed this drug. Try to not only that try to go on working on this mutation, also is going to work on this one. Okay, that's why this drug is like is successful, even though there's resistant mutations are there. Is going to work on this mutation by blocking this like the stamp is one of the thing that is a special the way of this drug is working and definitely you can see that those are mutations you can see that they had tried a very worst outcome actually may not achieve the people we lose the we are lost a patient in a couple of months also months to in within a year also you can see that we have other data with even 5 years several data also with this kind of thing with this T315 mutations actually that is they try to have best outcome with this asinib actually you can see that and we have the data like you can see that various molecule how you see that discontinuation and how you try to develop the mutations rate with the different because we have all the molecules tesatinib elatinib imatinib bosutinib like all the things you can see the chance of the resistant mutations are very high. Acinibis is as a potential to address this unmet need in the CML. Those are not addressed by the what us we used to use all the molecule ATP competing TKs. That is why it works by that is other mechanism known as STAM. And also that overcoming the other resistant mutation to other previously exposed to that ATP binding sites. You can see that cumulative incidence of MMR like as a days passes. You can see that you try to have highest possible durable DMR. You try to get it and measure molecular response also. And you can see that MR4, MR4.5 also is best with the when you're exposed to acinine compared to the other molecule. And safety also we are already we got in second line also is very convincing actually We have a slight thrombocytopenia sometimes. Most of the time, it is easily acceptable. The more of is a very favorable toxicity profile compared to the other drugs actually now compared to the bosutinib all the thing. We have like uh, the monotherapy with this. We have almost like up to 8 years of this one demonstrated to continue our continues to have a maintaining MMR like that is a DMR all the things that definitely that is it is first randomized control the phase 3 data of using the second generation as a competitor like you try to use this in a chronic myeloid leukemia previously already failed to 2 lines. You can see that we have the compare asinib when compared to the bosutinib it is try to have the best outcome after 3.7 years asinib is continue have superior efficacy better safety tolerability compared to the bosutinib. Response are definitely deeper and deep benefit is there. Any questions are they very happy to take. I'll stop here. Thanks, well, like my expert Dr. Vikram and Induja. I'll stop here. Like I'll stop my slide sharing and uh, I request organizer to continue the next session. Thank you.
Thank you, sir. Thank you, Satish, sir. Thank you very much for excellently navigating us through the journey of the CML treatment. Still, in the treatment of CML, the most difficult question seems to be the choice of TK, which one to start with. With
Yes,
this
yes,
first
yes.
line data of asciminib coming up, so robust data, and we know that the drug is very efficacious and safe. So maybe it might find its role in the first line itself. So we are
Yeah,
lead,
that
we are u-
yeah. See, the problem is when the data comes means that people like slightly there we have maybe selectively use only affordable patient. Their patient are like they want to use it. Okay, cost is not a factor. Later that when the number of usage and people are like we're using the data comes Indian data. I think people are using. Then people are getting convinced actually by that sharing with the conference that experience with all the clinicians definitely will convince and we try to use it. And next is about the importance of the cost is a very important in our Indian patient. Nowadays, it should come with a new formula, how to support in a first line with a different PAP program all the thing. That's one thing we can try to push more in a first line rather than second line all the thing. That's what I want
Yes,
to
sir.
say.
I hope they
Thank
are
you.
listening too.
Yeah.
Thank you, Dr. Induja and Dr. Vikram as well. As we are running short of time, I'll start sharing my slides. The next session is on our experience with letter mover. I'll start sharing my slides. Hope my screen is visible.
Yes, sir, it is visible.
Yes, sir.
And I'm audible also.
Yeah.
Yes. Thank you very much. At the outset, I would like to thank the sponsors of this session. So I'm going to share our experience or the Indian experience of letter mover for CMV prophylaxis. If you ask me, there are so many novel drugs which have come in the context of hematology or in the context of transplant. If you ask me what is one drug that is used by almost every transplanter across the country for all allogenic transplants, if I may say, that one drug is letter mover and which is used for cytomegalovirus prophylaxis. So most of the individuals have been exposed sometime in their life to this infection called as cytomegalovirus. The primary infection might not have manifested sometimes, but after some time, the infection will become latent in the body. The reservoirs for this latent infection could be myeloid progenitor cells, that is the CD34 positive stem cell, or a monocyte, or an endothelial cell. And they are latent for many years in the body. However, when there is a chance for them, when we give chemotherapy or immunosuppression, strong immunosuppression, particularly during a transplant, that to hematopoietic stem cell transplant, there will be a loss of T cell immunity, which is going to fight against these cytomegalovirus. And that is when the reactivation of this infection happens, and that can entirely spoil the homogeneity in the patient of allogenic hematopoietic stem cell transplant. It has direct effects on the patient and also has indirect effects on the patient. What are the direct effects? CMV is one virus that can involve every organ in the body. It can involve the brain, cause ependymitis. It can involve the eyes. It can cause CMV retinitis. The intestines causes CMV esophagitis and colitis. It can involve the liver, that can cause CMV hepatitis, CMV pneumonitis. Almost every organ it can affect in the body. Not just the direct effects, but also indirect effects. It can cause problems with immune dysregulation, or it can delay the immune reconstitution process itself, and it may contribute to graft versus host disease, or it may contribute to the allograft rejection also. So all of these problems will be very, very important in something called as non-relapse mortality in a patient of transplant. So how will this happen? Most of the times the CMV has a chance or a potential to reactivate in the early part of transplant. Thus, it can reduce the overall survival of the patient following allogenic stem cell transplant. So when we do a transplant, we are worried about two things. The most important one is relapse, which most of the transplant physicians do not have control on. The second is non-relapse mortality, where many of us have a control over it, and CMV related problems are some things which can be controlled. So patients, needless to say that HSCT recipients are at increased risk of CMV infection because of their immunosuppressive status, and it can manifest into a disease and also associated mortality. So patients with a positive CMV status before the transplant is a strong predictor for CMV infection and disease as well. So as you can see, 2/3 of patients can have this CMV seropositivity after allogenic transplant. So it is across all indications, all types of transplants, acute myeloid, lymphoid, chronic myeloid, and MDS. All these patients undergoing transplant, they have a significant non-relapse mortality because of CMV reactivation. So what is the drug that can help here, which can be used either as primary prophylaxis or as secondary prophylaxis, is letermovir. So letermovir is a CMV DNA terminase complex inhibitor. It is indicated for prophylaxis of cytomegalovirus in adult and pediatric patients both. In pediatric individuals who are more than 6 months of age and older and weighing at least 6 kg, who are CMV seropositive to begin with in an allogenic stem cell transplant. It is also indicated in patients of kidney transplant recipients also as prophylaxis of CMV disease in adult setting as well as in pediatric, but above the age of 12 years or weighing at least 40 kg, that too particularly in the high risk subset, that is the donor seropositive and the recipient being seronegative for CMV. What is the mechanism of action? How does letermovir cause this or prevent the CMV reactivation? So it inhibits the CMV DNA terminase complex, which is very, very crucial in the viral DNA processing and packaging and thus multiplication of the CMV DNA. So letermovir blocks this CMV DNA terminase complex and thus the multiplication of the cytomegalovirus. So it is very, very specific to CMV. There are very, very few off-target effects, and it is 1,000 times more potent than the existing drug that is ganciclovir. And as we all know, the problems with ganciclovir when we use in the early part of the transplant is they reduce or they cause the myelosuppression and the entire graft will go for a 6. So letermovir has been active against some ganciclovir resistant strains of CMV as well, and it has no significant antiviral. It is very, very important that even when the patient is on letermovir, we should always keep them on prophylaxis for herpes reactivation. That is, acyclovir is a must when the patient is on letermovir. So when to start prophylaxis? This data tells us when to start. This is a paper published in 2017 in the New England Journal of Medicine. So early you start after the stem cell infusion, earlier the better are going to be your results. So across studies, the median time of starting is usually between the day 0 to day 7 of transplant. So immediately after the stem cell infusion. Sometimes you can see blips, what I'll discuss in the later half of the talk. There will be fewer blips when letermovir is started soon after the HSCT. If you start later, there will be more blips, and that will actually lead to the confusion whether to start treatment or to continue prophylaxis or what. So lower risk to miss early reactivations, that too particularly before the engraftment. If you have a CMV reactivation before engraftment, then your transplant journey or the patient's transplant journey is not going to be smooth compared to the other patients. So if you see the outcomes in patients who have received letermovir versus those who have received placebo in the initial trials, it was 51% versus 86%. But when the time came for the phase 3 trials and more number of patients, that is 325 patients have been included in the letermovir arm versus 170 patients, that is 2:1 randomization of letermovir versus placebo. If you see at 24 weeks, at 200 days post-transplant, only 18.9% had CMV reactivation on letermovir, whereas it is more than 40% in patients who have received placebo. And if you see first 100 days, which is very, very crucial in the allogeneic transplant, the reactivation of CMV was only 6% compared to 41.3% in placebo. So this is where letermovir changes the game. So the prophylaxis for CMV, the phase 3 trial, it is used in more than 18 age group individuals undergoing hematopoietic stem cell transplant, multicentric study spread across 20 countries, CMV seropositive recipients, and undetectable CMV to begin with before randomization, and able to start treatment by day 28 post-transplant are included in the study. Exclusions were severe liver impairment or severe renal impairment and recent CMV antivirals the patient had received. The dose is 480 mg per day, but the best part is we can dose adjust it to 240 mg when we are using with cyclosporin. I'm sure most of the allogeneic transplants will be using cyclosporin as a part of their GVHD prophylaxis as well. The other arm patients have received only placebo, and the monitoring is through week 14 and then weekly through up till week 14, that is day 100, and then once in 15 days up till day 100, and after that it is only once in 2 months. So you can see that patients of all age groups and across the CMV status and all indications for allogeneic transplant have been included, and different types of transplant, the ones which are high considered to be high risk, that is the matched unrelated or mismatched unrelated transplants, are also equally distributed in both the arms, letermovir and placebo group of patients as well. And coming to the conditioning regimens, ATG uses, alemtuzumab, they are almost equally distributed in both the subsets of patients. You see what happened, the letermovir prophylaxis, if you see the end points, the patients who have received letermovir prophylaxis had only 18.9% reactivation at week 24 and only 6.8% reactivation at week 14, which was significantly lesser compared to the placebo arm. And then at 24 weeks also, if you see, it is 18.9% versus 44.3%. And it is not just in all individuals. If you differentiate them or risk stratify them according to the risk group, the high risk group also showed a similar, you can see the Kaplan-Meier curves are distinctly differentiated between the letermovir group versus placebo group, not just in the high risk group, but also in the low risk group. So it means that across the risk stratification, CMV prophylaxis should be considered. And if you see the cause of death, that is the cumulative rate of death, that is a non-relapse mortality in patients who have received placebo versus letermovir, again, there is a statistically significant difference in the total cohort as well as in the high-risk cohort and also the low-risk cohort. So CMV is not only helping the CMV, the reactivation of CMV, the letermovir, but also reducing the non-relapse mortality of the patients. So if you see the forest plot of 100 days post-transplant, most of the parameters are in favor of letermovir. That is, even in the high-risk patients, the reactivations are less. In patients who have received mismatched unrelated donor transplant or unrelated donor transplants who are considered the traditional high-risk category for CMV reactivation, in almost all of them, the data is favoring letermovir. Not just at 100 days, if they are monitored till 200 days post-transplant also, all the parameters are in favor of letermovir. So there's nothing challenging that, or there are no concerns to start letermovir, and it only helps. And most important concern while using the other drugs for prophylaxis of CMV, that is what we had previously, that's ganciclovir injectable and valganciclovir oral preparation, they always come with myelosuppression and nephrotoxicity. So not just the efficacy, but also from the safety point of view, letermovir patients had no myelosuppression and no nephrotoxicity, making it a safe drug to use even before the engraftment has happened. So valganciclovir and ganciclovir are only considered after the engraftment. And there's one more drug which can be used if there is a CMV reactivation despite of letermovir or without letermovir also. If the CMV reactivation happens before the engraftment, foscarnet is one drug. However, it is not readily available in the country and it has to be procured from abroad. And coming to the complications like GVHD, the diarrhea, nausea, fever, rash, almost every side effect which was expected to come are lesser in the group which has received letermovir. So to conclude this trial, the diverse populations who have been exposed different types of transplants to letermover prophylaxis. All of them have shown that letermover is effective in preventing clinically significant CMV infection through day 100 of transplant, and they are not associated with a higher rate of myelotoxicity or nephrotoxicity. So these are the traditional high risk. How do we differentiate people at higher or low risk of CMV reactivation? People at high risk are there is at least one mismatch in HLA A, B, or DR, or it is a haploidentical transplant, or unrelated donor with at least one mismatch in ABC or DRB1, or it's an umbilical cord stem cell transplant, or it is an XYO T cell depleted transplant, or we are using alemtuzumab, or grade 2 or greater GVHD. So, or the patient receiving prednisolone at a dose of more than 1 milligram per kg per day. So these are the group of patients who are at very, very high risk of CMV reactivation. So letermover prophylaxis is a must. That is non-negotiable in this subset of patients. However, we have shown that in low risk patients who are all do not have these high risk subsets come under the low risk, but even in them, the CMV reactivation and all cause non-relapse mortality is lesser in patients who have received letermover prophylaxis. So what is the exact duration? So usually from day 0 onwards, anytime we can start the letermover. This is the prophylactic letermover at least until day 28, but it is better if we continue at least till day 100, that is week 14. And after that, we can just observe the patients or put them on letermover. This is the study where they have continued letermover up to 200 days. This is a 2:1 randomization of letermover versus placebo. You can see 200 patients receive letermover and 100 patients receive letermover. 100 patients received placebo. And here they studied what happens if we give from day 100 till day 200. Is it safe and also efficacious? You can see the baseline parameters, both the genders and also different regions and all indications of transplant and all the high risk versus low risk are equally distributed or similarly distributed in both the groups. That is the intention to treat versus the placebo group. And if we see the efficacy endpoints in the primary efficacy population, if you see failures from week 14 to week 28 are also very less. So earlier it used to be a notion that letermover is used in the early part of the transplant, that is in the first 100 days, and it is used for prevention of CMV. But it can be used from day 100 to 200 also if the logistics permit, and it will reduce significantly the CMV infection compared to 18% in the placebo group versus only 1% in the letermover group. And initiation of preemptive therapy based on documented cytomegalovirus is less than 1%, the need for any further treatment when the patient is on letermover, whereas it is up to 15% if the patient is not on letermover. So it essentially means that from day, you need not stop it on day 14. If the logistics allow and the patient has a full chimerism and has no active GVHD, or if the patient has some GVHD needing steroids, it is worth continuing letermover in those patients rather than stopping abruptly at day 100. So 28th week clinically significant CMV infections, or as we saw the data just now, in the letermover arm were only 1.6%, whereas in the placebo arm there are 17.6%. So thus reducing the need for any preemptive therapy up till 200 days of transplant. So earlier the notion was 100, now we can consider giving it up to 200. So this was the initial one. So CMV, people used to start preemptive therapy by just monitoring initially. Now they start the patient on letermover prophylaxis and then stop it at 100 days. And then if there is any reactivation, preemptive therapy used to be started and then continue a secondary letermover prophylaxis. But it is the CMV viral copies, even if they are negative, continuing letermover prophylaxis up till day 200 is a worthy exercise and does not come with any problems. And is it helpful as a secondary prophylaxis, not just primary prophylaxis? You can see the data in patients who have already received ganciclovir, valgan, foscarnet, or cidofovir. In almost all of them, letermover has definitely made a chance. And all of those patients who were not responding to those drugs or received a preemptive treatment and then put on secondary prophylaxis, they have received up to 118 days median, ranging from 26 to 396 days. In almost all of them, only 4 patients, 5.5% of 80 patients developed a CMV breakthrough infection. So not just primary prophylaxis and not just 200 days. After somebody received a preemptive therapy also, it can be considered continuing as a secondary prophylaxis. So what is the optimal duration? This is the ECIL 10 recommendations which have come out in 2024. So letermover is recommended as the strategy of choice for preventing CMV for primary prophylaxis in adult LOHSCT recipients. It is recommended to start as early as possible after your stem cell infusion, but not later than 28 days post-transplant. Prophylaxis should be continued at least till 100 days. And if at all, if it is possible, that too in patients with high risk for CMV disease, we have just discussed who are those at high risk, it is worth continuing up at least until 200 days. For some individuals, there might be a need for continuing it longer than 200 days, particularly if the patient has an active GVHD and is on steroids, but that is left to the physician or the treating transplant physician's judgment. And coming to the pediatric setup, priming for letter mover is almost similar to the adult, whereas it should be started in adult setting as early as possible after transplant. The duration here also is at least until 14 weeks, and in high risk subset only, you have the luxury to extend here. Can we separate real reactivation from letter mover blips? What are these letter mover blips? Blips means a low level DNA which is detected when we are doing a routine monitoring of the CMV viral load. I'm sure everybody is aware that during transplant weekly, we monitor the CMV DNA. So letter mover usually inhibits the CMV terminus complex. Therefore, there will not be a proper viral DNA packaging. So, but there can be some fragments of DNA which are not properly packed. We know that PCR will pick up that kind of DNA also. So if there are some DNA fragments which are non-infectious to the patient are present in the blood, still it picks up. So, but what is the difference that it is real versus blip is the numbers are usually very, very less. If you see, usually we consider, depending upon the center, around 1,000 or 2,000 as significant. During the blips, people get very, very low level positivity that is close to 70 or 240 or 88, these numbers, because the limit of detection of CMV for any lab is close to 50. This will be just above that, and these come sometimes and just cause confusion. So how do we differentiate between the real CMV versus blips when the patient is on letter mover is after the starting of letter mover. If it is immediately after the starting of letter mover, most of the times it is blips because just the drug has started acting. Whereas if it is late from starting, it might be real. But what we should do is immediately we need not act. We just have to see the serial monitoring. If the viral load is increasing, then it is more likely a real CMV reactivation. Whereas if the increasing viral load is not there, it is usually a blip. And the viral load, as I just told you, it is usually around 50s, 100, 200s, maximum of 500s. But if the viral load is high in thousands, it is more likely you are dealing with a real reactivation. And the number of tests positive, just one or two tests, one-off test coming positive with a low viral load, it is usually a blip. Whereas if it is several loads which are coming positive, then we are dealing with the real infection. And then coming to the pharmacokinetic profile, why is it important is it is a moderate inhibitor of CYP3A45, and it is an organic anion transporting the polypeptide, and it's a P glycoprotein. The importance is because cyclosporine inhibits several transporters which are responsible for the metabolism of letter mover. And when the patient is on cyclosporine, the smaller drug itself will result in 2 to 3-fold increase in the letter mover exposure. That is why the dose needs to be halved. So when the patient is on not on letter mover, the dosage is not on cyclosporin, the dosage is 480 mg once daily. But if it is co-administered with cyclosporin, the dose has to be decreased to 240 mg once daily. If the patient is discontinued on cyclosporin because of any reasons like cyclosporin, we all know that it can cause TMA and things like that. So if the patient is discontinued on cyclosporin, the dose has to be promptly increased to 480 mg once daily. If the cyclosporin dosing is temporarily interrupted because of the high levels, because we know that the cyclosporin levels are still in the body and affect the pharmacokinetics of letter mover, the dose need not be adjusted. So this is the dosing based on the age of the individual. 30 kg and above, the dose is 480 mg. 15 to 30, it is 240. 7.5 to 15, it is 120. And less than 7.5 to 6 kg, it is 80 mg. And as we already discussed, the dose adjustment with the letter mover. So with that, I'll conclude the session. Thank you. If there are any questions, I'll be happy to take.
Thank you, sir. Anyone has any questions? Okay, so move forward. Thank you,
Dr.
everyone.
Revant,
Yes, sir.
Go ahead, sir.
so Dr. Revant, so in your experience, for which patient you start letermovir?
Sir, to be precise, for all allogenic transplants, we are using letter mover prophylaxis after the drug is made available.
So
whatever scenario.
as we know that the CMV reactivation, especially in mass sibling donor transplantation, is quite low.
Yes.
So do you still justify
Yes.
the cost, and you using this particular drug in this low risk population, or is it indicated only in haplo where the risk of CMV reactivation is quite high?
Yes. So first thing about the cost. So thanks to Zydus. Before Zydus brought this drug to India, it was prohibitively expensive, no doubt about that, and nobody used to use it unless there is a pressing issue. Once Zydus has brought the generic version of letermovir, the cost is very much accessible and affordable to most of the patients who are undergoing a haploidentical or an allogenic transplant, which is usually in tens of lakhs at least. And coming to the second question, the matched sibling donor transplant. The reason why haplo has more chance of reactivation and matched sibling donor has less reactivation is, I'm assuming that your question is based on the PTCY. We use the post-transplant cyclophosphamide. But most of our matched sibling donor transplants also, these days we are moving towards post-transplant cyclophosphamide, with which our results or the GVHD has been significantly less, and with the usage of letermovir, even the CMV reactivation also. So that is helping us in getting better outcomes of the transplant. So in matched sibling donor transplant also we are using. And the third point I would like to say is, even in the matched sibling donor transplant also, we have seen certain situations where the donor is positive and sometimes the donor's child is a is a matched sibling donor, very rarely though, or who is the recipient is negative for CMV. So in such situations, we are definitely using letermovir.
So one last question, sorry.
Yes, please.
So,
Yeah.
so if there is a reactivation, do you treat these patients similar to the patient who are not on this particular drug,
Yes,
like
of
using
course.
Gansig?
Yes, of course, we'll treat exactly the same way. Right now, we have a child of immunodeficiency as we speak, who has had CMV reactivation while on letermovir. That too happened before the engraftment. So if the CMV reactivation happens before the engraftment, our go-to choice is foscarnet. And if the CMV reactivation happens after the engraftment, of course, it is ganciclovir. We treat exactly the same way, despite of the patient being on or not letermovir.
Do you use artesunate in case if you don't see the response?
We have tried in a few
Do you
patients, sir. I
use
know that we
artesunate?
used to use. Yeah, so we have tried in a few, but the results are not so encouraging.
Okay. But we do have a good number of cases where we, after 2 weeks of therapy with ganciclovir, if we don't see response, our general tendency is to add artesunate because we work in a regional cancer center, which is mostly government supported. But we have a very good results with adding artesunate to the ganciclovir. Just wanted to add
Yes,
that point. Thank you
yes,
very
yes.
much.
Thank you, thank you, sir. If there are no further questions, shall we conclude?
Thank you everyone for joining us today. Give us your valuable time.